A brief review of Bell's palsy by Sanjeev Bagga, MD, Diplomate of American Board of Radiology and Nuclear Medicine. This short review is for medical students preparing for the foreign medical graduate examination. Bell's palsy is idiopathic sudden unilateral peripheral facial nerve palsy. Its symptoms include half-sided paralysis of the upper and lower face. It is important to rule out other causes of facial nerve palsy mimicking Bell's palsy, namely diabetes, which can be ruled out with serum glucose, sarcoidosis with chest x-ray and serum ACE levels, and Lyme disease, a disease caused by Borrelia burgdorferi, transmitted to humans through the bite of infected ticks. Symptoms include fever, headache, fatigue, and a characteristic skin rash called erythema migrans. Treatment for Bell's palsy includes lubrication of the eye, intermittent use of an eye patch, and for idiopathic facial nerve palsy, corticosteroids. Nearly half the cases of facial nerve palsy are idiopathic. Idiopathic facial nerve palsy causes swelling of the facial nerve due to an immune or a viral disorder. The common viral causes include herpes simplex virus, which is the most common, and herpes zoster, possibly the second most common. The other causes of facial nerve palsy, which are treatable and can be distinguished from Bell's palsy, include diabetes, Lyme disease. The facial nerve palsy is typically bilateral, unlike Bell's, which is unilateral, and sarcoidosis is a common cause of facial nerve palsy in blacks, which may be bilateral. Again, a distinguishing feature. A word about correlation with anatomy. The facial muscles are innervated peripherally, i.e., intranuclear innervation by the same-sided seventh cranial nerve, and centrally, i.e., supranuclear innervation by the contralateral cerebral cortex. So central innervation is bilateral for the upper face, meaning forehead muscles, and unilateral for lower face. This is an important fact to be remembered. The central and peripheral lesions tend to paralyze the lower face. However, peripheral lesions, i.e. facial nerve palsy, tend to affect the upper face more than the central lesions, for example, stroke. Facial nerve has a motor and a sensory component. Both emerge at the lower border of pons. The motor part supplies muscles of face and scalp, including stapedius, platysma, stylohydra, and posterior belly of digastric muscles. Sensory part supplies taste fibers to the anterior two-thirds of the tongue. Symptoms related to Bell's palsy include pain behind the ear, which often precedes facial paralysis. Patients have numbness or heavy feeling in the face. The affected side becomes flat and expressionless. Patient cannot wrinkle the forehead, blink, and grimace. In severe cases, the palpebral fissure widens and the eye does not close, leading to conjunctival irritation and drying up of the cornea. The sensory examination may be normal. External auditory canal and area or the mastoid is painful to touch if the nerve lesion is proximal to the geniculate ganglion. Salivation, taste, and lacrimation may be impaired, and there may be hyperacusis. During the management, it is important to protect the cornea, prevent its dryness by frequent use of natural tears, isotonic saline, or methylcellulose drops. Corticosteroids are useful in idiopathic facial palsy, and if given within 48 hours of after onset, result in faster and more complete recovery. Antiviral drugs like acyclovir, which are effective against herpes simplex virus, have been used but have shown no definite benefit.